not get in it, so we just have to come back in the corner.
Okay.
It's radioactive.
There are a lot of you who are tall and are in the front. Please go in the back. And there are a lot of you there, over there. They are small and are in the back. You have to turn.
Okay, all the tall people get in the back, short people up front. And we prefer vertically challenged.
The woman with the white hair. Yeah, this lady.
There we go. Check him out there. Check him out. Make sure he's okay. Right up the duck.
Okay. Okay. Nee, ich glaube, das wird nichts. Some of you, can you go on the tables? On the tables.
I'm not doing that.
Like Dr. Siegel. So besser? Geht nicht anders. Geht so? Siehst du jetzt alle?
Lori Halverson, get it up here. Come on, we're hot and tired. These people have paralysis.
Ja, anders geht's halt.
You want a chair?
I'll never get up.
We can get you a chair. You don't
Chair. I can have a chair.
How about a chair?
Here for a chair.
Here we go. There you go, Doc.
I'll never get up. Believe me.
So, Jamie, you guys want to use one on the other side?
How's that? Is that good?
Okay.
All right.
Okay, over here.
Ich stelle mich da vorne irgendwo.
You're not going to do the split?
now.
Thank you, all the children and teens, please.
Good job. Okay, hang on. We're figuring it out. We've got it. We're good.
You've been taking care of us.
Okay, everybody, please, while we're getting the children ready for the picture, or the young adults, sorry, y'all. There have been several people asking if they have a way to communicate with others that are here at the conference, because odds are we don't all remember everybody's name. So anybody wanting to do that, we're going to set up pen and paper by the front where we had registration. If you are interested, put your name on there, your email, whatever you would like, and if you are interested in communicating with each other, just use your cell phones and take a picture of it. All right? Thank you. Have a nice day.
What'd you say? I didn't even hear a word you said. Spence. Guys, come over here.
What?
Repeat that when everybody's sitting.
What?
This is where the young adult picture is.
Yep.
Hey, you might want to repeat that when everybody's sitting, because I couldn't hear you when I was trying to hear you.
Okay.
When will the list be out?
Well, if you want to write your name, and then everyone can have, like if there's several sheets, just take a picture of it.
I don't get a cell phone. Yeah. So just,
Do you have an email address? Yeah, that's probably the best way to communicate it. You know what? I'm going to go delegate and have someone be in charge of that so that they can email everybody.
yes, I'm
How about that?
yes, everyone.
Yes, I'm going to
That would be good.
I'm going to put someone else in charge of that.
I'm like playing really tight.
People are already writing their names and so you make my life a lot easier. Make the list, email all of them to each other. All I do is email and then everybody has everybody. I'm getting really good at delegating. It's an open mic. If you're not in a picture, could you please sit down? We're going to get ready to ask questions.
No, we're going to get ready to hear Dr. Cannon.
Oh, my bad. We're getting ready to hear Dr. Cannon.
So we'll just start, and everyone will mill back to their seats, etc.
Hi, I think I'll just go ahead and start in the interest of time. And I don't mean to monopolize the microphone this morning, but yesterday we didn't realize there was going to be such an early hard stop for lunch, and there were several topics I wanted to provide you with updates on research. We got through 3 of the 5, and I offered to continue this morning, and it seemed like there was interest, so let's go at it. When we were in Orlando a couple years ago, I talked about the fact that really directed through an understanding of the regulation of electrical excitability of muscle and what goes wrong in the hypo-PP mutations, that there was good rationale for trying a medication called bumetanide. It's a very potent diuretic, so you might think that's paradoxical. It would lose potassium in the urine. But what it does, it's an inhibitor of a cotransporter that in particular is very important for moving chloride into muscle, as well as sodium and potassium, but chloride's the relevant thing here. So I hate to make the story even more complicated because you're talking hypokalemic periodic paralysis, so you're involving potassium, but I have a calcium channel mutation, and now you're telling me you got to worry about chloride, but that's the way it is. So you got to bring all the players in. And this was the data I shared with you last time. Just to remind you, we have knock-in mutant mice models where we have either sodium channel or calcium channel based periodic paralysis. And when we study this in the dish, as you can remember from yesterday, if we electrically stimulate this muscle in the setting of a low potassium challenge, the force is much less. So there's the phenotype. And so the question was, if our line of reasoning was on target, would this drug bumetanide be beneficial in this assay in the dish of the performance of muscle function? And so here are the results from our mouse model of hypo-PP due to a sodium channel mutation. So you're looking at individual force responses, contractile force here in control in this animal, in the muscle. Then in the low potassium challenge, you see how large the decrement in force is. And then even while staying in low potassium, if a very low concentration of this drug bumetanide is added, there's a complete recovery of the force. And the concentration that was used here was a micromole, which means relevant to what could be achieved in the body if someone were to take this medication. The results were also promising for the calcium channel-based hypo-PP. Again, we gave ourselves the challenge of inducing an attack and then trying to effect recovery. You see the recovery wasn't quite 100%. That was a consistent finding in the calcium channel mutations. But it is reversible, the attack, if you wash out and put in normal potassium. I will say that if you give the medication before inducing the attack for either sodium or calcium channel-based hypo-PP, it was incredibly effective at preventing an attack from happening in the first place. So we're excited about this. It's a potential alternative therapy. Could be an adjuvant to other things that are being used. I will say that despite the fact that we've known this now for a couple of years and have even published it, that we're not yet spreading the word and asking neurologists and primary care docs to necessarily prescribe bumetanide. You can, it's available by prescription. The reason is we still want to think about safety because of the double-edged sword nature of this. While it can help the electrical status of the muscle and maintain excitability, on the other hand, there will be potassium loss in the urine, and so that's something that needs to be balanced. So when we showed this, Mike Hanna's group, I should also say, yesterday I talked about challenging the muscle with an acid load to simulate exercise and the post-exercise weakness. The bumetanide is very effective in that challenge as well. So when I presented this several years ago, Mike Hanna's group at the University College in London, Doreen Fiallo is the lead investigator on this, said, this is promising enough, we should follow it up in patients in a controlled way. And they designed a proof of principle trial. And what this involved is enlisting people who had confirmed hypo-PP. All of these individuals, 9 are in the study, happened to have calcium channel mutations. The protocol was to come off your med. You could keep taking potassium, but if you were taking Diamox, to come off of that 72 hours before the test, then have the CMAP exercise test to look at the electrical excitability of the muscle, verify that you as an individual with hypo-PP did indeed have the abnormal decrement. In doing the compound muscle action potential after a couple of minutes of exercise of one of the hand muscles, instead of maintaining constant amplitude of the CMAP, meaning excitability of skeletal muscle remains intact, those with hypo-PP and hyper-PP for that matter will have a decrement in the response. The point is this test will show this abnormality only about 60% of the time. So the design of the study was to make sure somebody was indeed going to have an abnormal test response, and then once the amplitude had decreased by at least 40%, to give an oral dose of either bumetanide or a placebo. And in the first couple of trials, it was hard to stay blinded because the people who got the drug had to pee. So what they did was have everyone drink copious amounts of water so that then did in fact become blinded because everybody had to pee. So this is unpublished data that has already been presented in a public forum at the Muscle Study Group in Utah last month, and so I'm able to share it with you. So based on the size effect they thought they might see, the goal was to enroll 12 patients within a year. They were only able to get 9 in 3 years. Interestingly, a lot of people, understandably, didn't want to come off their carbonic anhydrase inhibitor for 3 days. That was one of the limiting factors. So the outcome is that, fortunately, there were no adverse events from taking a single 2 milligram dose of bumetanide, in the sense that nobody had documented dramatic fall in potassium, nor did anyone have an attack triggered by administering bumetanide, which is an important safety consideration. There was a small improvement in terms of recovering more quickly to a normal CMAP, but as of this stage, with only 9 patients, it was statistically not significant. And the level of analysis was sort of just at the first screenings because the investigators are still blinded, so we can't look for little tiny details that we will be able to in a secondary analysis once the blinding is undone. Interestingly, 2 out of 4 of the patients who received bumetanide said they had a general improvement in sense of well-being and strength that lasted for a day or so, not just the CMAP, whereas that didn't happen on anyone who got placebo. So where we are on this is that more work needs to be done. One of the concerns is that while this was a very rational and well-designed approach to studying whether bumetanide would be effective in patients with hypo-PP, that the short exercise CMAP test isn't everything, and that the idea is that now maybe there needs to be, now that the investigators are more confident that it was safe, nobody had an adverse event, that we can try this as an abortive therapy in a controlled trial, self-reporting in an outpatient setting. So that's what the London group is considering doing. I still remain optimistic. It makes a lot of sense, but I would still use caution and don't reach for this yet as something that we can sanction and be overly enthusiastic about. So, questions about bumetanide? Yeah. So bumetanide, the question is, do you take it one time? Bumetanide has a very short half-life, so that's one of the good things about it. If it doesn't agree with you, it won't last very long, but it would make it a challenge to use it prophylactically day to day. You would need to take it 3 times a day at least. And because it is such a potent loop diuretic that causes substantial potassium loss, we would not recommend thinking about taking this prophylactically. But if you feel an impending attack, it could be used in an abortive sense, or even in the middle one if you're able to swallow. Perhaps even someday, if you're particularly troubled by exercise-induced attacks and you know you want to participate in an activity, you could take it just before that. But that's the kind of use. I'm sorry, I can't hear you.
I tried it, what I told you, and my potassium go down, but I took it too much, I think.
Yeah.
I will try it again.
Yeah. So, with caution, maybe take potassium supplementation half an hour before it, because it's absorbed very quickly and very fast effect for the bumetanide. Yes? The question is, could you take it along with Keveyis or Diamox? You could. It's a different mechanism. Non-overlapping shouldn't be contraindicated. The carbonic anhydrase inhibitors cause very modest potassium loss in the urine. So you're now having two mechanisms both working towards that. So you'd want to be cautious. To me, yes, you're taking your potassium. Yeah. Okay. Again, I will be here for the roundtable, so if more questions for this come up. And let me just finish up the last topic, which is the fact that there are now new muscle syndromes that sort of have overlap, sort of periodic paralysis plus, in relation to identified sodium channel mutations. So I thought you might be interested in learning about those. I'll start with an individual that came to the Mayo Clinic in Rochester now almost 20 years ago. This woman has had severe weakness since birth. There's a fatigability to it rapidly over seconds. Here you can see she's being asked to hold her arms out to their side, and they're sagging, and her knees buckling because she's already feeling weak. Her face is, you see her smile is weak. Her eyelids are a little droopy. She has a head tilt. And it also impacts her breathing. She had hypoxic events as an infant, unfortunately, and has some cognitive problems because of that. This constellation of symptoms is suggestive of one of the congenital myasthenic syndromes. So these are diseases where, because of a gene defect, there's a problem with the way the nerve communicates to the muscle. So not, usually in the muscle itself. It can be the receptor or presynaptically in the nerve itself. But when they tested her for all of those features of congenital myasthenia, all those tests were negative at the Mayo Clinic, which is, they wrote the book on the whole thing, right? So they gave a very comprehensive study. Surprisingly, what they found was a mutation in the sodium channel. And what it appears is the communication between the nerve and the muscle was completely fine, and the postsynaptic response in the muscle was fine, but it just couldn't induce an action potential in the muscle, and that's why this person had weakness. I know this is all small print. All these little letters mean where this mutation occurred is a highly conserved place of the channel. Curiously, in this affected woman, there were 2 sodium channel mutations found. And her sister and her mom were asymptomatic and had one of these mutations, the S246L. Dad wasn't available for testing, so we don't know whether this other V1442E was also in the father. The father was known to be asymptomatic, but we didn't have genetic testing. So that raised the question of, was this a recessive condition? After all, the proband has 2 mutations, and that would make the mom and the sister a carrier. Or was this a dominant mutation? So we collaborated with the group at the Mayo Clinic and functionally measured the channel properties, and I know these are technical details, but what this plot is showing is the availability of a sodium channel to open, that is to participate in the generation of excitability and the action potential as a function of the voltage of the cell. And the point is that normally you sit at a voltage where your sodium channels are about 100% available, ready to participate in this electrical signaling to generate the action potential. Because of the mutation, the V1442E mutation in this patient, the voltage dependence was shifted way towards your left, which means in a normal resting cell, already about 90% of the sodium channels would be inactive and unable to participate. So this is a function, this is a loss of function, whereas every other sodium channel mutation that had been found in hyperkalemic periodic paralysis and myotonias were all gain of functions. So this was really interesting way back in 2003. And we heard nothing else about it. And we thought this was going to be the zebra of all zebras, right? One person in the world. And then there was a report 12 years later by Arnold and colleagues of a patient who looked like myasthenia. Droopy eyelids, reduced eye movements, fatigable weakness, and also had a sodium channel mutation that was recessive, so 2 copies of it. And here is, again, this sodium channel availability versus voltage, and you see that left shift for the mutation, so the same kind of effect. Then a patient was referred to our clinic at UCLA, evaluated by Perry Shea, a 6-year-old girl who had fluctuating strength with episodes of breathing difficulty. Again, a lot of weakness around the face and the soft palate, looking a lot like myasthenia with a little bit of myopathy on top of it. Carbonic anhydrase inhibitors did not help in her case, unfortunately. Turns out there wasn't electrical evidence of a myasthenic syndrome, but otherwise things look like this. Unfortunately, her sister had episodes of breathing difficulty and died at 1 year of age. And this woman turns out to have a mutation also in a recessive pattern. So both her parents are carriers. They're both completely asymptomatic. And this child has 2 copies and has the same shift in the voltage dependence of inactivation. So we're now up to where there are 5 individuals, all of whom have this mixed syndrome that's like periodic paralysis plus, the plus being a lot of myopathy and features suggestive of congenital myasthenia. And all of them were recessively inherited mutations of the sodium channel. Interestingly, if we go back to our cartoon of the channel as it sits in the membrane, and each of these colored blobs is the location where a mutation has been found in, hyper-PP, hypo-PP, et cetera. All of these loss of function defects are all in the same region of the channel, and it's the region that's most important for the voltage dependence of inactivation. So it all makes complete physiologic sense. So just wanted to make you aware, we're having to change our diagrams, sorry, going the wrong direction, of our thought of the spectrum of diseases that come with sodium channel mutations. Then the group in London sort of approached this in the other way. They had a large cohort of patients with a syndrome that's called congenital myopathy, which basically means from birth, these infants are very floppy and have severe muscle weakness that impairs gaining motor milestones, things like rolling over, sitting, walking, things like that. It's already well known that this is a very heterogeneous group of patients that have a variety of genetic defects, but many of them were just unknown. And because the technology is now available, they did whole exome sequencing, sequenced all the coding regions of the entire genome for these patients, over 100 patients. And 11 of them had sodium channel mutations from 6 unrelated families. 7 of these 11 cases were very severe, with death either in utero or within the first day or 2 of life. The 4 who survived had, again, marked floppy muscles as infants, weakness off around the face, difficulty swallowing with breathing. Interestingly, some of them improved with age. They were able to walk. Here's one individual. You can see the high arched palate, a long face from weakness. She's pushing against the wall. You can see the shoulder blades sticking out with the scapular weakness. And all of them are recessive, in which case the parents, sometimes they were things like first cousins, so it was in a family, sometimes 2 different mutations. And some of these mutations weren't point defects with a single substitution, but there was a more destructive genetic lesion where it completely destroyed the coding potential of the channel. What it means, it was a null. You couldn't make a sodium channel. And those parents who had 1 normal sodium channel and 1 null were completely normal. So this was a big surprise to us that you will be asymptomatic even if you're only carrying 1 normal copy of the sodium channel gene. We've actually made a mouse model, and we find very similar things in the mouse. It's important that your partners in Invitae and Strongbridge doing the gene testing, I wouldn't be surprised if with the throughput of screening coming up, we might disclose some other null mutations that had previously been unrecognized because individuals are asymptomatic. That's just the sodium currents showing that they're small. So I like to think of it in this diagram. You have, of course, 2 copies of a sodium channel, 1 from your mom and 1 from your dad. You can either have 2 normal copies. You could have 2 completely non-functional copies that can't make a sodium channel. That turns out to be lethal in utero. You can have 2 copies of a point mutation that severely compromises the function of the channel but doesn't completely eliminate it. In that case, you get this myasthenic syndrome with overlap with periodic paralysis. If you have a 50-50 poorly functioning channel and the other copy of the gene being non-functional, that's the much more severe congenital myopathy. And amazingly, you can have just 1 loss of function or 1 null, and you'll be completely up in the phenotypically normal group. So this is sort of changing our picture. And you've seen this diagram before where we talk about the symptoms that patients with muscle channelopathies experience, either myotonia or periodic paralysis. These are all the sodium channel ones, either just sodium channel myotonia or PMC and hyper-PP. These are all gain of function mutations, which means the mutation causes the channel to be open more than it should and more sodium flows in. As we discussed yesterday, the hypo-PP mutations all cause leaky channels. So that's a completely different functional class of defect, and you get a different clinical phenotype. And now what I'm telling you this morning is that there are these 2 other groups that either have an overlap between myasthenia and periodic paralysis, which is a recessive loss of function, or a much more severe congenital myopathy, which are loss of function sometimes in partnership with a null. So we talked about the other disease things from yesterday. So I'll just finish up. We talked about this yesterday by, again, thanking a lot of collaborators who over the years have both referred patients and helped us do these studies. And I'm happy to take any questions, or we can immediately transition to the roundtable, whatever the group wants to do.
We have a question here from the last segment. Dr. Cannon.
On the butamine, or however you pronounce it, I have two questions. One is I'm already hypotensive, so I was wondering if it affects your blood pressure, how it might. And the other question is, I always have mild metabolic acidosis, so I was wondering how that affects that also.
So the low blood pressure would be a relative contraindication. You would want to be careful about that because blood volume will decrease. It is a powerful diuretic, so you want to make sure you're well hydrated, or if you had a dose in a safe situation where you're sitting down, perhaps careful how quickly you stand up. Either to be naturally in a state of chronic acidosis or secondary to carbonic anhydrase inhibitors, that would not be a contraindication to the use of bumetanide or similar drugs. Again, I'm excited about this. What I want to do is roll this out in a careful way, because if people get a little overexuberant and some adverse events occur, it could taint the whole picture and we might miss a treatment opportunity. So.
Can you go back to the first slide on the myasthenic, the 2003 paper?
The individual or the mutations? You tell me when to stop. Oh, yeah. I was just curious. Sorry. Both mutations on that, there are traces from both mutations. Yeah, so at the time of that paper in 2003, sorry, don't get dizzy looking at this, we waffled over whether this was recessive. Because, so here's the wild type, and here's the one mutation and the other mutation. So both of them caused a little relative loss of function. They did go to the effort to show they were on the separate alleles, so it's not.
But I'm curious if it could be loss of function because the message is not translated. This is overexpressed in a heterologous system. So this data looks. I mean, the one allele certainly looks like it could well be a causative allele, but another possibility is that this doesn't matter at all, that the message is not stable or the protein's not stable, and you have loss of function as a result of having way too little protein.
Yeah, so the interesting thing is just the relative extent, and the mouse model tells us that if you have just one really bad allele, you're right on the verge, because if we stress that mouse at all, you get pseudomyasthenia and failure of repetitive firing, and so that could be the situation here. But I agree with you. The newer ones are much clearer, which is why we weren't promoting this story until now. There are 5 patients, and all the genetics in the case are much more straightforward in those. Yeah.
What I would like to do now is maybe just have all the speakers come up, and we'll still have more questions. And if you have more questions, just ask them. But we'll do it in that context. mic's for you.
Dr. Cannon, this goes back to your presentation from yesterday. You said that the perfect medicine you said the perfect drug would be one that could block the gating pore leak. Is that going to be where you're looking next, or where is your research going next?
Great question. That's one of the eventual goals. Right now, we're finishing up studying all the previously described mutations to make absolutely certain this is the consistent anomaly, and therefore where we should focus our attention. One of the challenges is measuring these is technically very difficult, so it makes the development of a high throughput screen of many small molecules a challenge. The other thing we'll do is, because the structures of these channels are known in greater detail from crystallography, X-ray crystallography, and other techniques, maybe we can get a picture and make a good guess of what a blocker would be. But that is one of our goals, certainly. Yeah.
I have just one more question. In my family of R528H, calcium channel, we've noticed something. On those of us who did the 23andMe testing, excuse me, we've noticed that those of us that have the worst PMW also have another gene. We have two copies, or we're no for both copies of the alpha-actinin 3, you know, the gene for speed. Yeah. So we're no. And the ones who have absolutely no PMW, but clearly have R528H, have two copies. They've got the C's, two C's. The ones who have some, but they're moderate, have one C and one T. So it just seems like such a coincidence, and I'm wondering, this is for the whole panel, what do you think about maybe a modifying gene also having some impact on the degree of PMW?
Great question.
There's certainly going to be modifier genes. My genetic expert I'll return to.
Yeah, no, I think that's very interesting. And it, again, you can't say from a very small number of patients that this is absolutely true, but it's such an interesting observation that makes sense to me. So I agree with you that this could well be a modifying gene. And so one very interesting thing that could be quickly done is that for everybody with R528H calcium channel mutation, to get genotyped by someone to test that other potential modifier, and then in a large enough, if there were, 20 people with the mutation who have very mild, or who don't have permanent muscle weakness, and 20 who do, if there's a real disparity in terms of the number of alleles for the second gene, one could test that statistically and essentially prove or disprove that the second locus is that particular null allele is associated with increased risk for PMW. So I think it's we make observations in single patients and we say, oh, that gives me a great idea. This looks really interesting. This could be it. But to prove it now, it would need to be extended to more people. But that's a trivial thing to do. So I applaud you for figuring that out. And now the question is, can it be tested in a larger group of patients? This is something maybe that Stonebridge would be interested in, since they're going to be genotyping people and they're going to be getting. I don't remember the details of how they're going to be sequencing, what they're going to be sequencing, but that data may be available from those studies, and I'd love to look at that and help analyze it.
I have a comment on modifier genes. Quick question for Dr. Cannon, perhaps. Way over here. You mentioned in your experiments there talking about acid base and its such on muscles, and somebody else mentioned that they were in mild acidosis. And I found a note from Dr. Lehmanhorn talking about patients being on CAIs being in a bit of state of acidosis and recommending perhaps using sodium bicarbonate to buffer that. Any comment on like trying to find for patients to find a balance between acidosis and not to find best performance?
Great question. So I'd say the most important thing is how you feel as an individual. And my current thinking about a common mechanism for all the carbonic anhydrase inhibitors is it ties to the metabolic acidosis that it induces. And I've talked to some others just in random conversations, and my advice is don't treat the numbers. So you get a blood test that will tell your bicarbonate level and chloride. Don't let your physician get overly focused on that, and don't adjust your medications necessarily based on that. Change it on how you feel, and make sure that your caregiver is comfortable with the fact that you're supposed to have a metabolic acidosis when you're on carbonic anhydrase inhibitors. You need to be there in order, I think, in order for it to be effective.
I have a question on how do we help prevent the false conversion disorder diagnosis, not only in kids, but just in general. I know that there are a lot of people, like I said, that have fought that, the conversion disorder, the false conversion disorder diagnosis. How do we address that, or how do we help fix that problem?
I'll let Mickey Siegel speak because he's done all this diagnosis, but I'll say, fortunately, the tools for objective diagnosis with the exercise test or now genetic testing is helping somewhat, but as many of you in the room know, it's not a panacea. You might not have a recognized mutation.
I don't know of any magic answer other than, 20 years from now when everybody's being having their genomes checked as part of their medical treatment, that problem will probably go away. But in the meantime, I think there's some educating of you folks to know of resources about this, and also educating the doctors and trying to make it part of the protocol for diagnosing conversion disorder, that you have to check for some of this stuff. Now, unfortunately, there isn't a perfect way to check it. Some people have high creatine kinase, also called CPK, but some people don't. And we're sort of afraid of saying, why don't you check the creatine kinase, because then if it's normal, then people will say, oh, you don't have it, you're crazy.
Comment on the potassium. A lot of people think if your potassium's normal, you can't have it.
Right, and so well, even what Steve Cannon is saying is that with the potassium, classically during, so first of all, the potassium level of a person with periodic paralysis during attacks, when they're between attacks when they're fine, is no different from that of the regular population. During the episode, it's typically low, although it isn't for everyone. And typically everybody's potassium fluctuates, and when my potassium gets to some low level, I'm sort of vaguely aware of it. When your potassium gets to a low level, you can get paralysis. And furthermore, once you get a paralysis episode going, the muscles swell and take up potassium. So the potassium goes even lower and it gets worse. And I'm not really sure how one actually gets out. What is it that gets you out of it eventually? But it does work. And so we don't have totally simple rules, except that it would certainly be good if people could check potassium, because if it's very low, then that would tell you that that this is real. And so one of the things you should do is you tell people, I have this diagnosis. If you have a genetic diagnosis, give them the specific mutation. Anybody who doesn't know how to deal with that will at least realize that you know something more than they do about this. And that's why we wrote this owner's manual for hypokalemic periodic paralysis. it might be good to sort of have something. There's a resource for doctors called Gene Reviews, which the doctors will read. It might be nice to have a sort of gene reviews for patient owners' manuals. If somebody has some good idea of trying to talk with various foundations of developing some of those. But you should know the appropriate gene reviews article about your condition, and maybe even just print out the first page of it and bring it to the doctor and make them feel that you know something that they need to know.
So I have a comment on the modifier genes that possibly should be looked at a little bit more. There's a very common mutation in people of European descent called the adenosine monophosphate deaminase deficiency. About 20% of people with European descent have one copy of this, and if you're homozygous for it, then you definitely have trouble. And so it's something that is believed to cause a lot of trouble when it's mixed with another neuromuscular disorder, a purely muscular disorder. And so at 20%, having this, where you need extra ribose, and it will create special fatigue issues because of the excess adenosine. You get 20 times the adenosine after eating if you're homozygous. And so I'm just thinking for the panel, this may be something worth considering as a modifier gene, because at 20%, having one copy European descent, that's very common. And even 2% for a double dose, if they're periodic paralysis and adenosine monophosphate deaminase deficiency type 1, then they're going to be in a lot worse trouble. So it's just a comment for a modifier gene.
Yeah, I agree.
I have a question for Dr. Cannon, but anyone who can weigh in on it. It had to do with when you were talking about cell damage yesterday and then permanent muscle weakness, and we're a table interested in this answer. Is it your opinion that if you have a severe full body attack, say once a week, is that going to cause more cell damage than someone who's maybe having less frequent attacks, or more frequent attacks but less severe?
So very good question. The key part of that is, what is your opinion? Because it's only going to be an opinion. Our understanding of what leads to the permanent muscle weakness is very rudimentary. You can see the damage on the muscle biopsy. We cannot connect the dots to know how you get there. I might have said this yesterday, but if I didn't, you should be aware that there's a very large R528H hypo-PP family in the Netherlands, multiple generations, over 50 affected individuals. And this is one of the situations where there's the gender difference. The women many times do not have a single recognized acute attack, and then later, age 50 and 60, begin to get permanent muscle weakness. So that would be the counter argument. You don't need to have any attacks and you can still get weak. The other hand, it could be a level of awareness. It could be, well, you've lost 15% of your strength and it just hasn't reached the extent to which you would complain about it. On the other hand, I would agree with what other people have said with the big electrical changes that happen and the shifts in ion concentrations and the edema and the swelling. That is wear and tear on the muscle fibers. And I think it's just prudent to do the best you can to minimize the frequency and severity of your attacks in the hopes of maintaining strength and not having the permanent weakness later.
Hello? Sorry. I'd like to ask a little bit of a different question angle. I just thought maybe while we had all the zebras in the room, maybe if we could ask some questions to you guys and have the doctors notice if these things affect any of you or if it's just me in particular. But first of all, if you could have the zebras raise one hand, and then once I ask the question, if you have that, raise both hands, because it's kind of hard to tell how many are supporters and how many are the actual people with the diagnosis. So my questions are, how many of you have noticed that you have like multiple chemical sensitivities? So if you If you're a zebra, raise one hand. If you have that, please raise two. I've got both. I've got that. Okay. And then, okay, that would be something like, and that's the thing is sometimes the more you learn, the more you go, wow, this is something that really affects me. So it's things like perfumes or colognes or shampoos or what am I thinking? Cleaners, Windex, anything like that. That type of those things. So you come around those and they make you just feel horrible. You just feel awful from them. Okay, the next one is I was wondering about mold sensitivities. And now, if you're a zebra, raise one hand. If you have it, raise both. Because this has been a huge effect for me. I have to, and I've been studying, and it says it's a gene thing that makes you be more sensitive to mold. So I wonder if that has something to do with this too. Okay, and then the next one is, and I don't know how many of you are aware of this, but for me, my disorder affects both my lungs and my heart, and so it's very life-threatening. So everywhere I go, I have to ask them, we've had motels that we've had to get out of quickly because my attacks won't quit. And until we realize, my husband will call down to the office and say, have you recently sprayed with pesticide or herbicides? These are neurotoxins that they use in this, and it actually has a potassium dropping effect on the insect, and that's how it kills the bug. So this has such a big effect on me. So I don't know if you have noticed this, but anyway, if you have, and if you haven't, please become aware, because study it, look it up. It is a neurotoxin, and it does drop their potassium levels, and it does it to me severely. So if you have that and you know you do, please raise your hand if it's zebra, raise your hand if it affects you.
One should point out that some of these insecticides that are sprayed also have other volatile organic compounds that may be affecting you in a similar way to the perfumes and so forth.
Yeah.
So there's multiple ways in which some of these things could be acting.
So, and I just thought maybe even for our website, if we could put on there pesticides and herbicides, because if you look it up, they really do say that they drop potassium levels and that they're neurotoxins. So that would be something for people to be aware, because it's life-threatening for me, and I really have to take care of that.
I'm sorry, but I have a plane I have to catch, and so does Dr.
Oh, no.
I'm always happy to come to future meetings. I do the Answer the Expert blog that Jake forwards me, many of them, but I'm sorry.
Okay, no problem. So thank you guys.
Well, then, I have a question for Dr. Siegel.
I've suddenly become very popular.
That's right. I believe it was during Dr. Weber's presentation yesterday, he listed different types of stressors for hypokalemic periodic paralysis. And one of them was hormones, specifically estrogen. Could you speak about the mechanism and why that's a problem? And I know pros and cons about taking hormone replacement therapy, but for a postmenopausal woman with leg weakness, is it contraindicated?
I know specifically that that things like epinephrine, adrenaline can cause problems. I know specifically that steroids can cause problems. I don't know the details of the estrogens, but I presume that Dr. Weber is more familiar with that. But it's not surprising that these things can have effects, and one should believe them.
I think that the testosterone and human growth hormone and estrogen probably have some beneficial role, but there's always risk-benefit. I'm not good with the endocrinology. I know that estrogens after 35, especially if you're a smoker, gives risk for breast cancer, uterine cancer, and deep vein thrombosis, which a blood clot goes to the lung. So you have to really balance the risk-benefit. Best person to ask would be an endocrinologist or a gynecologist.
I was just curious why it was on a stressor list for periodic paralysis.
Oh, not sure. It's probably, more than anything, it might be an observed. It's just an observation, so they...
Hi, I have a quick question, and maybe Dr. Schiffman can address this if at all possible. I know we talked about CoQ10 and magnesium. Does anyone have experience with carnitine or molybdenum or any other supplements that could be helpful?
I think that's going to be kind of an anecdotal situation. Sam, do you have any comments on that? Not so much. That's going to be real hard. I mean, I think there's going to be some people in the room who say they've tried it and it helped. Other people, they tried it, it didn't help. So long as it's not particularly harmful, there's no reason not to try it if you're really stuck. That's the best guidance I can give.
Thank you. Hi there. I'm going to shift my question since the other fellows left. And so many of you from the board, thankfully, are still here. This was my first time coming to one of these. And, first I wanted to just thank all of you, especially those of you on the board and those who support the PPA. This really meant a lot to me to, for the first time ever, meet somebody with the same condition. It was really uplifting. And my my husband had a great idea with those mice that maybe you could auction those off next year. And then those of us who go home, have nobody that we've ever met with it, we'd at least have company with us to watch our little mouse, So, anyway, so I guess I have so many questions, but I think I want to really prioritize with one thought that's really been on my mind over the years, and that is that when people are trying to find a diagnosis for this disorder, so often they're really struggling to sort through the maze. It's very complicated. How do you go about it? What do you do? The PPA is here for us. We're so thankful. But my gut feeling is that with all the good research that's being done out there, all the researchers who are doing incredible work in these narrow areas, that what we really need is to have more of a bridge with the PPA in particular, because I think the PPA is in a great spot to do this, to bridge with our internists and our family practice physicians. They're going to be the ones that are with us through this whole process, because many of us live in small towns. Maybe one of them, we raise sheep. We're just in the middle of nowhere, And so I think if there was a way that we could empower our internal medicine physicians, our family practice physicians, to really feel like they are the expert, because they always feel like, even from a legal standpoint, I'm just, this little peon, I don't know anything about it. But they're the ones, if we work with them, I have been so blessed with an internist that for 13 years worked with me, and we had a great relationship, and literally, she was a lifesaver for me. But even more importantly, if this guy, he says, don't tell anyone, but he's an ER physician, and he has literally saved my life, because I have a form of the periodic paralysis that now affects the respiration. And if it wasn't for him, I wouldn't be here to, be able to talk to you. And so I'm just saying, these frontline people, whether it's him, trying to figure out what on earth are we going to do, in the practical way. Your internist who's saying, I don't know what to do, but I'm here for you. And I'm just saying, these people are worth $1 million. Let's do everything we can to bridge this gap that exists between these very, very erudite, important people, and I mean, they are doing good work, and I'm very grateful. But let's try to help these people on the front lines who we encounter not every day, thank God, but many times we're going to encounter them, and they are going to feel like they're a nobody. They don't know what to do. Let's get concrete guidelines. I know it won't hold up in court. I know. I totally get that. That they're going to say you have no pool, you have an N of 1, and here you're telling us to do this or do that. But I'm saying we have to keep working at it because we're real people. We're stuck in our real situation, and I don't mean that we're alone. I believe that God walks with us, and that's why we're here. I mean, but the fact is we have to have this concrete help in a practical way, and I'm just asking if the PPA could make that a focus.
So here's the thing. I can't call your doctor because then I'm meddling. But if your doctor calls us, then we can put it to the appropriate expert. So I always say, if you get your doctor to write into PPA Ask the Experts, give his cell phone, give his email, then I can reach out and send him any information. Yes. And yes, I agree. We need guidelines, and Strongbridge is helping to fund, experts to get together to make guidelines and things, and then push that out there. But definitely, if a doctor asks, tells us, then we can give the information to the doctor. And it would seem to make a whole lot of sense to, rather than say, let me mail it to every internist in the country, just mail it to your internist. So you have the disease, your internist needs the information at the very least. So, there should be a mechanism of doing that. Many doctors don't want to bother, unfortunately.
Right.
There's one other resource that's very widely respected among doctors are articles from the series called Gene Reviews, and there's one for hypokalemic periodic paralysis, there's one for hyper, and some of the other congenital myasthenias. A bunch of them have them. And these are very good articles. In our diagnostic software, we always refer to those if they're available. Similarly, there's some Orphanet articles in Europe. I don't remember if they've really covered the periodic paralyses well, but that is one resource. As Jake mentioned, working through the periodic paralysis, ask the expert type of things that can connect with people. Another is specifically some of the questions like the one that you folks brought up about is if you can pick one of 3 things off the shelf, is lactated ringers a good choice? Right. This is something that we should try to direct experiments about, write a paper, refer to it in a guideline, have a list of things. Periodic Paralysis International has a bunch of pages like that. In our owner's manual guide, we try to refer to a bunch of those. So we have to make these resources to both empower you and empower your doctors, because that's the only thing that's going to work. You can't educate doctors about 10,000 different conditions and expect people will remember it.
I have a question about, I guess it's kind of about treatment. I'm hyperkalemic PP, and like everyone else, when I get sick or catch a bug, I get dehydrated. Because I take Diamox and hydrochlorothiazide, that can happen quite rapidly, and sometimes even if I don't have a bug. And what I'm wondering is how to rehydrate, because all the electrolyte drinks all have potassium, so I'm often advised to go off my medication for a couple of days, which then causes a lot of other issues.
When you say rehydrate, are they saying drink water or get IVs?
Well, I'd like to. I mean, what can I do other than going to get an IV prior to going to get an IV? I'm wondering how I can avoid.
Drink water. What's wrong with drinking water?
Well, it doesn't always rehydrate you quickly if you're dehydrated, right? That's why people do the electrolyte drinks. And
so dehydration specifically, indicates that you're low on water. Mm-hmm. If you're low on electrolytes, you have to substitute the electrolytes. So I think if it's just straight up dehydration, it's water. If you're not sure where you're going, then you're going to need a blood test to see what's exactly going on in terms of supplementing electrolytes. That will guide what drink you could do. Yeah.
Okay. I'm also wondering for there was on the slides it said listed infection or illness as a trigger, and I'm wondering if that's because of that it messes with electrolytes and sometimes medications, or if there's some other mechanism at play that causes
I think we're not sure.
Well, one part where we really do understand it is if you have a gastrointestinal infection, that will cause changes in potassium levels very dramatically. I think primarily through losing potassium in the gut as opposed to lack of absorption. So gastrointestinal infections are definitely have a big effect, and one should know about it. And for somebody who's hypo, they should know that if you're having gastrointestinal problem, know that you should probably be taking more potassium. And it's a problem because it can also cause diarrhea, but at least you should understand what's going on and how you need to deal with it.
But as far as the flu or that, we don't understand the mechanism.
I wanted to piggyback on, kind of expound on her question she was asking, and I know a lot of people, maybe not necessarily here, but out watching the conference. One of the big burning questions of the day is how do we the word she used, bridge, between those of us who are living day to day with this condition that is not well managed because we don't have physicians and experts or access to them ourselves on a day to day basis. How are we connecting all of this great knowledge that we had here today and all this great experience that was here today? How do we connect those of us who need that help to these experts and kind of actually use, because they need us, right? You guys need us so that you can learn from us. We need you so we can learn how to better manage our health. What are we doing? Is there a clearinghouse for how we can all connect?
Well, I think this is it. I mean, we got all the experts here, we got you here, and we're sharing. The problem is that not every piece of information presented here is relevant to any one person, and the physician has to be motivated. If you give the physician a booklet this thick of all the ins and outs and little tricks of the trade, it's not relevant to them. They don't care about how you're dealing with anesthesia if you're walking in for a cold right now. So it has to be it's almost like we have to give you guys the information, you have to sift through it, and when you see that, I have a cold, you go to the frequently asked question of, what do I do if I have a cold? Here, this little paragraph, and just kind of, we have to be educated consumers.
And I appreciate that, and totally I'm there with you. But I was just wondering more along the lines of there's research opportunity, or you guys, so when they're doing a research thing, how do we learn about that so we can be part of that? And how do we actually get to find an expert and travel to that expert where we can at least get some good stability and then bring that back to our doctors?
I think and I think the most efficient way right now is we have PPA Ask the Experts. We have a medical advisory board. Every one of those medical advisory boards can be emailed. If you do PPA Ask the Experts and say, I want to speak to Dr. Cannon, I will forward it to Dr. Cannon.
And then we can make appointments with these physicians and travel
that's
and
provided
see
they
them.
take your insurance and they want to play ball, and not everyone wants to play ball. Some of them do, some of them don't. And you cross your fingers that they're into it.
So we just kind of have to keep doing the footwork, trying to reach out to
Yeah,
these
but
providers and see
I've
who will
never
see
not
us.
forwarded on a message or anything,
Yeah.
So I'll advocate
So
for
go
you.
through
Yeah.
Okay, thank you very much for that.
And one other thing that happens informally is that I know I've spoken to a bunch of people's doctors at various points, and I assume the others have as well. And there'll be things that don't come up in the general resources and questions, or if they just want to hear a warm body connected to whatever. We all recognize this is a tough situation, and we are here to go to bat for you.
I have a question similar to Anita's. I'm looking for fellow zebras as well. My name's Annette, and I live in Utah. And my son Michael and I and my 7-year-old daughter have clinically been diagnosed with hypo, but we suspect ATS. Dr. Potacek suspects ATS type 2. And our heart problems don't seem to be, Michael has had long QT on Holter of 668, but we don't have arrhythmias. And we have coronary artery spasms that cause very, very intense chest pain. Sometimes also mild chest pain, but it comes on with our periodic paralysis episodes. And it's brought on by all the periodic paralysis triggers, and it's brought on by missing our periodic paralysis medicine. and it can be resolved by taking our potassium. And when it gets really bad, it takes a very large dose of potassium to stop it. And so I'm looking for other people with the same thing. Dr. Potacek and Dr. Cannon both agreed to look into whether the smooth muscle might have ion channels that could be affected by Anderson-Tawil syndrome. So I'm looking to see if we're alone, because no one seems to have ever mentioned this before. Thank you. So would you raise your hand, please, and maybe I can count? And would you mind if anyone's willing to contact me afterwards? I would really appreciate it.
Can I interrupt
So
you?
Sure.
We're going to have battling mics.
No, I'm just kidding.
Sure.
Oh my gosh. Okay. This is Shauna. She has agreed to collect the emails from anyone who wants to communicate after the conference.
Okay.
I had mentioned it, but I think people couldn't hear me. Up at the front desk where we did registration, there are about 4 or 5 pads of paper. Just print your name and then a hyphen and your email very legibly, and this lovely lady, is going to take care of it. She'll group email all of us, and then you can just send one out and say specifically what you need, and we'll be able to all contact with each other. And Jake and I are both on it, so
wonderful.
Thank you.
Hey. And we're having a conference next year in Dublin.
Yay!
So Shelley wanted me to announce that too.
But if I could just quickly, who had that kind of chest pain that thought they might have the artery spasms? Thank you. 1, 2, 3, 4, 5, 6, 7. Okay, thank you very much. Sorry about that.
Excellent. No, it's okay. It's good.
Okay. So my question actually is for Eric. Because we keep talking about the PPA website, is it possible for you to bring up the PPA website and quickly just show us the website and how to navigate it?
Yeah, sure.
Thank you.
Okay, so I have to be on the other computer. Actually, the website is pretty straightforward. When you go to periodicparalysis.org on the net, you will get into the homepage, and with the menus on the left side, like here, you can navigate to the different information sources. Now, a couple of times was suggested already to bring your physician into our database. Now we have different things like medical advisors. They're already there. I will click it on, and you see all the pictures and all the names. These are the guys who are our medical advisors, but you can suggest a physician for yourself as well. So if you have a doctor which is very willing to work with you, but is not very well known on the periodic paralysis side, then just click suggest a physician and give us all the data we need to get them into the database. Oh, this is working very well, not. Okay, I got into that. Well, anyway, you can put in your physician, but still you can ask the experts as well. So what Jake mentioned earlier was if you have a question, oh, I'm not logged in. Sorry for that. You can only ask questions to the experts if you're logged in, which makes sense, otherwise we get so much mail. Let's see.
While we're logging in, we're going to run out of time in like 5 minutes or so. I think that any remaining questions, you can either write it on a piece of paper and give it to me, or put them in PPA Ask the Experts, and at the very least we'll forward them. And if you have a specific expert you wanted to ask, then, you know, like, ask that expert. There's a few people still wanting to ask. So just do it. Ask while we're waiting.
Okay, I'm logged in. Sorry.
Too late.
Too late?
No, go.
Oh, okay. I'm too late. Or not.
No, you're
I go.
late.
Okay, sorry. Ask the experts. Click it on the menu. Ask the experts. Agree with the terms. And then you got to actually a mail form
So that's the legal disclaimer to protect the PPA.
So then you get to a mail form. Put in your name, your email address, and the subject you're asking about, and ask your question. It will be mailed to Jake. He will answer primarily. But if the question is for any of the other medical advisors, he will forward it, and you will be answered over that. So there are different ways you can contact us through the site.
I think that's not. I think that's not possible. The way we've envisioned this. I mean, if you have if you have a question like that, you can ask on the listserv. The problem is that if it's specific to like your case, I'm going to be very reluctant to answer on a listserv publicly about recommendations and things. Where's the listserv?
Well, the listserv, you can go to the listserv on your profile. So if you go to My PPA, if you're logged in, you can check your personal data. And all the data over there is the things you put in yourself. And you got some checkboxes if you want to be on the listserv or the listserv digest. So click on yes and save it, and that's it. And then you're in. Yeah.
Sure.
Okay. I'm just a quick question that was posted online, so this is going to help people out of the country. Victoria Lidstone on Facebook group had asked about the Keveyis being available in Europe. Since we're all in the United States, we're only talking about that. So Stonebridge had offered to answer that question.
Do you want to answer your question first?
My question? My question was just about if there's a benefit in going into our local hospitals and letting them know our protocol, like what needs to happen to us, or talking with emergency people.
A lot, then definitely go tell the ER, give them a heads up, put it in the electronic medical record, have stuff that the target doctor should be familiar with. Absolutely. It's a great idea. That is like a really great idea.
Okay, and is there a guideline that tells us
And the fire department too.
Because I haven't had to go to the hospital, thank goodness, but is there a guideline online?
About what to do in the hospital?
To do in the hospital, yeah. That can go in there?
Yeah, it depends on where people look. But
Okay.
there is information available. Yeah.
Okay, thank you.
Yes.
So the question was getting Keveyis outside of the U.S. Strongbridge only has rights to Keveyis in the U.S., so U.S. only. That's the only jurisdiction that we have rights to the drug. Sun Pharma owns rights outside of the U.S., so for any questions regarding Keveyis access outside of the United States, please contact Sun Pharma.
In some Europe states, you can get kiwis with the International Apotheke.
Well, I guess this is going to be the last comment or question or comment, and then we're going to wrap it up.
Jake?
Huh?
Maybe this week, I live in the Netherlands, and maybe this week we can start Keveyis via Sun Pharma. We don't have a doctor in our country, so one needs a Netherlands prescription, is the right word. But I called our health insurance, told them it's Diamox with an old antibiotic or something like that. And then they agreed we're going to try. So after 2 years fighting, we can start, and maybe others can do that as well. Talk about it with your health insurance. Tell them.
So you're saying
what it
basically
is.
it's available in the Netherlands. If your doctor writes you a prescription, they'll get you.
Yeah. If
Okay.
they write a paper that they are responsible for you,
Right.
But that step is not necessary for us now.
Okay.
And in most countries as well, because they have the number.
It's not only Netherlands. No. Whole Europe.
Okay, so I mean, access issues. I think contacting Sun Pharma would be a good first start if you're not sure.
Okay. I hope this question applies to at least one of you. I am wondering about dental anesthesia, if anyone has had experience with nitrous oxide. And the reason I'm asking is because for a lot of people with this, it seems that they can do okay with the dental anesthesia as long as there's no epinephrine. And I am not able to have any of the local anesthetics, so I have to just do it without the anesthesia. And I'm kind of always looking for a way to get around that. And nitrous oxide, they've used for my daughter, you know, being a kid at a different dentist place, you know, and I thought, shoot, I wonder, and they still use a local anesthetic. But I just wondered if anyone here had experience or would know whether that might be an option. Laser. Oh,
So
say it again. I'm sorry.
There's no, I don't see any physiologic reason why it would be bad for periodic paralysis. So it's probably, you know, I would say worth a shot. But every individual is different, so it's you're always rolling the dice. But
exactly.
Yeah.
It works on me, and I have a lot of trouble with other general anesthesias. But there's a wide variety of local anesthesias, and so it may be worth exploring.
Tried them all.
Okay, well, so nitrous does not create episodes for me, whereas I've had lots of trouble with lots of other things.
Thank you.
all right, guys. So just let's give who, what, why. Yes, please make sure you give your emails to us, you know, on your way out, and just give yourself a round of applause. Thank you all so much for coming. Jeff is going to conclude it.
Come on. Before we leave today, I just would like for everybody to show your appreciation for everything that Dr. Jacob Levitt does for you. Yeah, let's hear it. Give it up for him. There you go. Thank you so much, and we'll see you in Dublin.